A warm welcome to Dr. Sarath Battina. Over to you, Doctor.
Good afternoon, everyone. I thank my good friend Dr. Jay Krishnan for giving me this opportunity. And one word about Dr. Jay Krishnan. Me and Jay Krishnan are good friends, and we always used to go to estate together. And this Obigani Club of Trivandrum is his brainchild. No? So it's celebrating his 25th birthday, and I congratulate him on this occasion. And 15 years back, when we went to Eshe, there was a demonstration of robo in that particular conference. No? So once he came back, he made the slides on robo, and he demonstrated robo about in that Obigani club. No? Still, I remember that, and memories are fresh in my mind. So he's such an intense academic person, and I wish him good luck. And with this brief about Dr. Jay Krishnan, I'll be starting my talk. No? My talk will be about low AMH patient and evidence-based approach. As all we know, anti-Mullerian hormone is an important marker of ovarian reserve, and low AMH patients will have poor ovarian response during ovarian stimulation for IVF procedure. Women with low AMH are stratified according to their age to determine the reproductive outcome of IVF. Stratified into Poseidon group 3 and 4. Poseidon group 3 and 4, they are expected poor ovarian responders with low ovarian reserve. AMH will be less than 1.2 or less than 1.2 nanograms per ml. Antral follicle count will be 5 or less than 5. Group 3 Poseidon group patients will be less than 35 years of age with low AMH, and they contribute about 10% of the total Poseidon group patients. When it comes to group 4, there will be more than 35 years with low AMH, low ovarian reserve, and they will contribute about 55%. These two groups with low reproductive prognosis pose a clinical challenge. To maximize the oocyte yield and to increase the likelihood of having at least one euploid blast for transfer, we have to individualize the various steps of IVF treatment. These include choosing appropriate individualized stimulation protocols, individualizing ovulation trigger strategy, and adjuvant treatments prior to and during ovarian stimulation. Coming to the stimulation protocols for low AMH patients, natural cycle and mild stimulation IVF were thought to be more optimal for low AMH patients compared to conventional hyperstimulation. They felt high dose gonadotropins thought to increase aneuploidy rates in oocytes and embryos, but recent evidence doesn't support this concern. Ovarian stimulation with exogenous gonadotropins of 300 IU recombinant FSH should be used rather than natural cycle IVF. DeVry and Pellicer, they have reported that evidence is showing that recombinant FSH is superior to HMG as a means to the oocyte yield. Berkanglo in 2010 has reported that maximum daily dose of recombinant FSH should be 300 IU per day, and higher doses don't increase neither the clinical pregnancy rate nor the live birth rates. Coming to the GnRH agonist protocols for low AMH patients. GnRH agonist protocol is the first choice for Poseidon 3 group patients. They're young, less than 35 years of age, and they have low ovarian reserve. Sungara et al., they have reported that when a long agonist protocol was used compared to antagonist protocol, there was a non-significant increase in the number of mature oocytes by one oocyte and a significant decrease in the cancellation rates. Humidin in 2017 has reported that long-acting gonadotropin, corifoliotropin alpha, for ovarian stimulation in low AMH patients didn't increase the pregnancy rate compared to recombinant FSH. However, he has concluded that significantly more embryos were available for freezing, which is likely to increase the cumulative live birth rate, at least one euploid embryo available for transfer. Coming to the antagonist protocol for low AMH patients, it is the preferred protocol for Poseidon group 4 patients. Follicular asynchrony, and age-related aneuploidy of the oocytes and embryos are contributory factors for poor prognosis in this group of patients. Follicular synchrony is achieved with either luteal phase estrogen where estradiol valerate will be given 4 milligrams per day for 5 days prior to the menses, or oral contraceptive pills for about 12 to 16 days followed by a 5-day washout period, which was reported by Garcia et al. In 2013. Again, this Velasco in 2013 has reported that pre-treatment with estrogens or OCP in antagonist protocol was compared to GnH long agonist protocol in two OCTs, and they have concluded that there was no difference in duration of stimulation, FSH consumption, and no embryos, and the number of embryos obtained and pregnancies were similar in both the groups, where antagonist protocol was compared to the agonist protocol when antagonist protocol was preceded by luteal phase estradiol valerate. So follicular synchrony can be achieved by luteal phase supplementation of estrogen, which will increase the oocyte yield. Coming to the dual stimulation, follicular recruitment and development happens in a wave pattern during the menstrual cycle, which will be manipulated in our stimulation protocols, making it possible for a dual stimulation. This strategy has helped to achieve 20% pregnancy rate in Poseidon Group 4 patients. According to a recent publication, the oocytes derived by luteal phase stimulation appear to increase the cumulative live birth rate in a single ovarian cycle in patients with uh, fulfilling Bologna criteria. So in this dual stimulation, so luteal phase supplementation with estradiol will be done to achieve the follicular synchrony, followed by, once the woman gets periods, she will be given recombinant FSH 300, optimum dose of recombinant FSH 300 IU per day, and the down regulation of the pituitary will be done with the antagonist. Then when the follicles reach maturity, 18 to 20 millimeters, what we will do, HCG will be given. HCG or GnH analog can be given for ovulation trigger, followed by oocyte retrieval, and the second day or third day of the cycle, again the stimulation will be started with optimum dose of gonadotropin, and this one pituitary down regulation can be done either with progesterone supplementation or by antagonist in the luteal phase stimulation cycle. Coming to the duostim for low AMH patients, antagonist stimulation cycle allows the use of duostim. Dual stimulation and double stimulation are considered to accumulate the number of blasts needed to increase the probability of having at least one euploid blast per transfer. There is no difference in the ongoing pregnancy rate for single blast transfer between blasts obtained for either from the follicular phase or luteal phase of the stimulation. 39.5% versus 49.4%, which was not statistically significant. Virally in 2018 has reported that the ongoing pregnancy rate with the duostim of 20.7% can be considered highly successful in low AMH patients. Humaydan et al. Have conducted a randomized control trial involving 939 Poseidon group patients. They were divided into two groups. One group received recombinant FSH of 300 IU with recombinant LH 150 units per day, versus the other group have received only recombinant FSH 300 IU per day. There was no significant difference in live birth rate between these two groups. But when the patients were stratified into mild, moderate, and severe POR, moderate to severe patients, poor ovarian response patients, had a significantly higher live birth rate and a lower pregnancy loss when 150 units of recombinant LH was added to the stimulation protocol from the day one of stimulation. Yeah. So both physiological as well as clinical evidence suggests that a beneficial effect of recombinant LH supplementation in the Poseidon group 4 patients. Coming to the adding LH for the ovarian stimulation protocols. Several trials looked at adding LH when there is a slow response, when follicular stagnation happens during ovarian stimulation, or excessive FSH consumption in the previous cycle, stimulation cycle, and reduced ovarian stimulation markers 4 and 5, and age older age group patients and high BMI patients, especially obese patients. By adding LH, there was an added advantage for this group of patients. And the data from more robust studies indicate that in slow responders, LH supplementation starting from stimulation days 7 to 10 might be more efficient than increasing the dose of recombinant FSH to rescue the ongoing cycle. Then we talked about ovarian stimulation strategies. Then coming to the ovarian trigger strategies for low AMH patients. These include individualized ovarian trigger strategy to increase the mature oocyte yield in this particular group of patients, which includes final HCG, human chorea gonadotropin, is the most commonly used drug for oocyte maturation and ovulation trigger, and but GnRH agonist trigger also can be given in antagonist cycles to prevent ovarian hyperstimulation syndrome. GnRH agonist trigger elicits a surge of endogenous LH and FSH, which will mimic the natural cycle, adding physiological benefit for the activation of the oocyte maturation. Live birth rate using GnRH agonist trigger with modified luteal phase support is comparable to HCG triggered cycles, which was reported by Humaydan et al. In 2017. Coming to the quality markers of ovarian response. Fourth, follicular output rate, and 5, follicle to oocyte index are excellent qualitative markers of ovarian response. They positively correlate with the outcomes of IVF, and they reflect the dynamic nature of the follicular growth during ovarian stimulation. 5. Follicle to oocyte index is the ratio between the number of oocytes retrieved compared to that of antral follicle count. So if the follicle to oocyte index is more than 50%, we'll consider it as normal, and if it is less than 50%, we'll call it as low FOI. Then coming to the fourth, follicular output rate. This is the ratio between the number of pre-ovulative follicles to that of antral follicle count. If fourth is less than 30%, we'll say that this patient is hyporesponsive to the administered gonadotropin, and if the fourth is more than 80%, we'll call it as adequate response. 4 and 5 values are highest in Poseidon group 3 patients, followed by group 4 and group 1, but the lowest in the group 2 patients. Low FOI and follicle to oocyte index and ovulation trigger. Mutations of LH receptor could be the reason for low FOI and can be improved by certain ovulation trigger strategies. Dual trigger and double trigger are introduced for the management of low FOI patients. These two strategies are suggested to improve the IVF outcomes by overcoming impairment in follicular function, oocyte meiotic maturation, and cumulus expansion. Double trigger. Both the GnRH analog and HCG will be administered 40 hours and 34 hours prior to oocyte pickup. When it is dual trigger, both GnRH agonist and low dose HCG are administered same time, that means 34 hours prior to the oocyte pickup. Both these strategies combine the advantages of GnRH analog and HCG in terms of LH activity and early luteal support modified mediated by HCG, and the endogenous secretion of LH and FSH mediated by the GnRH analog. In addition, double trigger might increase the maturity of retrieved oocytes in some patients who needed a longer interval between the ovulation trigger and oocyte retrieval, which will allow the cumulus expansion and detachment of the oocyte. Coming to the adjuvants for ovarian stimulation protocols. Androgens are the commonly used androgens for this purpose, and DHEA sulfate, dihydroepiandrosterone sulfate, and testosterone are the most commonly used androgens for this purpose. And mechanisms include androgens include FSH receptors on granulosa cells, leading to an increase in the recruitability and development of antral follicles through the action of IGF-1, insulin-like growth factor 1. Androgen pre-treatment may improve the live birth rate, and in POR patients, dose given will be DHA sulfate 75 milligrams per day for 2 months prior to the ovarian stimulation, and the testosterone will be given in the dose of 5.5 milligrams per day for 60 days prior to ovarian stimulation. Coming to the other important one is growth hormone. Adjuvant treatment with growth hormone in ovarian stimulation cycles is associated with increased production of growth factor IGF-1. IGF-1 upregulates the action of FSH, which in turn there will be increased ovarian sensitivity to FSH, proliferation of granulosa cells, which in turn will increase the estrogen production, augments aromatase activity. It will help to increase the estrogen production and promotes follicular maturation. It induces LH receptor formation too. It will be given in the dose of 8 to 12 international units per day from day 2 or day 3 of the cycle till the day of trigger. According to Cochrane Library, the use of adjuvant growth hormone in IVF treatment protocols has uncertain effect on the live birth rates and mean number of oocytes retrieved in normal responders. However, it slightly increases the number of oocytes retrieved and pregnancy rates in poor responders, while there is an uncertain effect on the live birth rate. Definitely, there will be an increase in the oocytes retrieved and pregnancy rates, but live birth rates were not, the effect on the live birth rates were uncertain. They have concluded that further research is necessary to fully define the role of growth hormone as adjuvant therapy in IVF procedures. Coming to the coenzyme Q10, the most commonly drug and mostly exploited drug in our infertility practice, which is responsible for electron transport in the mitochondrial respiratory chain during the oxidative phosphorylation for energy production. Acts as an antioxidant within the oocyte. Follicular fluid concentration of CoQ10 diminishes with age and correlated with the oocyte aneuploidy. Oral CoQ10 supplementation prior to ovarian stimulation for IVF treatment may improve the ovarian response and the follicular environment, leading to the improved oocyte and embryonic outcomes, which was reported by Zhu et al. In 2018. Coenzyme Q10 administration will decrease the mitochondrial oxidative stress, improving the oocyte competence for fertilization. And there will be significant improvement in oocytes retrieved, and more high quality D3 embryos will be available when co-administration was done. No adverse reactions with the co-Q administration. Dose given will be 300 to 600 milligrams per day for 2 months prior to ovarian stimulation. Melatonin. Melatonin is a potent antioxidant, has potent antioxidant activity, promotes oocyte maturation, fertilization, and embryonic development by protecting the oocytes and other follicle cells from oxidative damage. It reduces apoptosis of granulosa cells and increases the estradiol levels on the trigger day, which was reported by Devroy et al. In 2012. To conclude my talk, primary goal in the management of low AMH patient will be to maximize the oocyte yield to transfer at least one euploid blast. This demands individualized approach at all steps of ART treatment, which includes targeted pre-treatment evaluation, the choice of gonadotropin analog, gonadotropin type and doses, ovulation trigger, and the possible use of adjuvant therapies. So, future developments for the low AMH patients, Dr. Reddy has beautifully enumerated various techniques, which includes to improve the quality of embryos and to improve the implantation rate, development of oocytes from the stem cells, ovarian fragmentation and in vitro activation to promote follicle growth through different mechanisms. Fragmentation of ovaries promoted polymerization and disrupted ovarian hyposignaling, which in turn will increase the expression of downstream growth factors, resulting in promotion of follicle growth and the generation of mature oocytes. Additional follicle growth is achieved when ovarian fragmentation is combined with AKT stimulation treatment followed by autografting. With this talk, I conclude my talk and I thank you all for your patient hearing. I once again thank the organizing committee for giving me this opportunity. Thank you.
Thank you so much, sir. Thank you for that informative session.